Live from New York, this is Benefit with Friends. I'm your host, Lou Bernardi. Thank you for joining us today live, if you're out there. We have a great show today, important show, I think, really more than great. Real super important topic. We're going to be talking about the functionally uninsured. I have a guest with me today I've known for a few years, Aaron Witwer from ePowered. I'm going to bring Aaron. You know what? Let's bring Aaron right into the room. Here we go. Aaron, how are you?
I'm well. How are you doing?
It's too important a topic to waste any time. So I need to get you right in here. So for those of you that are new to the show, this is our 14th episode. Aaron and I are both involved with in some employee benefit, health insurance, advisor consulting organization. We've known each other for a while. And, you know, if you're new to the show, I'm Lou Bernardi. I am wearing this ridiculous shirt because I am the benefit optimization officer, formerly insurance broker, general agent. I coined the phrase because I think it's real important that we really change our mindset, especially on an employer side, what we're actually purchasing. You know, I think far too often we think of that we're actually buying insurance. You're not buying insurance. You're buying access to healthcare for your employees. And I think that Aaron would agree once I give him an opportunity to talk, that we've gotten off track. You know, we've allowed managed care over the last 30 years to take us somewhere where we don't want to be, right? Yeah. Very, very high premiums, excessive out-of-pocket cost, too many functionally uninsured people. And this show is about kind of sharing what we've learned. You know, I know that we've dug in deep. The last 5 years have been really very new for me, very challenging, very exciting. Found a lot of great people, a lot of great companies, a lot of great solutions, and can't wait to share those. If you're a benefit decision maker and you're frustrated with the status quo, if you feel stuck, if you feel like you have no choice but to accept insurance company premiums, then you're in the right place. And you know, and I got great guests. I don't know how I got Aaron. So Aaron Witwer is from ePowered Benefits, one of the premier benefit, you know, I'd say boutique. I don't know what that word really means, but sure. You know, doing things differently. So, you know, Aaron, I'm going to shut up for a second, allow you to introduce yourself and take it from there.
It is different. It is different. A lot of us are different these days, it feels like, but still not enough for our liking.
Yeah.
Well, thanks for having me on. This is fun. I mean, this is just like chatting with buddies, right? Like you said,
it is
benefits with friends.
That's it.
This is how you get stuff done.
You know, we've met each other a few times. We're probably going to be together again within the next couple of weeks, I think, at Benefits Pro, maybe EBN, whatever, you know, definitely online. And, you know, you mentioned chat. So I always fail to mention this, but I think if you're on the show, if you're out there, we can't see you really, but if you want to, I think you can use private chat or comments. If you have any questions for us, please feel free. I'll keep bouncing back to see where they actually land. But the functionality of this. So, you know, when I reached out to you and said, hey, would you like to be a guest on my show? You jumped on the opportunity and you immediately said, hey, this is what I'm passionate about. Yeah. Functionally uninsured people. And, you know, that's not a new term, I don't think, but I'm not sure that we spend enough time talking about it in the war rooms when we're talking to, you know, CFOs, CEOs, HR directors, heads of people, whatever terms, you know, I mean, BOO, whatever. We're not talking about that, right? We're so focused on this is what we have now. This is what our insurance carrier is presenting us. This was our claims. It justifies this increase. And what do we have to do to get to that targeted renewal rate that, you know, maybe comes out of the C-suite or the finance department within companies? But I don't think enough people are saying, hey, is what you're offering today functional,
right,
or meaningful benefit for your employees and their families? So I'm going to let you elaborate on that because you say it eloquently.
You know, the way I talk about this a lot is trying to change the conversation a little bit, right? With the C-suite, exactly as you alluded to, just to say, look, you probably don't even really want to be talking about insurance right now anyway. So let me just frame how much different this is going to sound. And so I want to start with the idea that you probably have people who make a variety of salaries and incomes at your company. And so what we haven't been traditionally good at is leveling the playing field. So everybody, equity, everybody can have access to primary care and high quality primary care. There's a lot of conversations about, well, everybody has access. Everybody got the plan. It's a PPO plan. Everybody, it's on, right? Well, it's not equitable about that. Well, it's the definition between equality and equity, right? Or equitable healthcare and equal. So equal means, and there's this great graphic out there. If anyone just types equity versus equality, even in a Google search, probably the first image that'll come up is 3 people standing on boxes looking over a fence. When you give everybody, these 3 people are different heights. If you give everybody the same size box, some people will still be able to see over the fence, others won't. What equity suggests is you give each person the size box that's necessary for them to see over the fence. That's what equity is. And that's a harder concept for folks because it doesn't feel fair. Well, they got more than I did, or they got something different than I did. But what it means and what we've understood, unfortunately, over the last few years is that equity, it is really, we can't just talk about equality. We need to talk about how do we meet people where they are. We like to say things like that, but where they grew up, what's their transportation needs? What are their educational needs? Are they health literate? Do they really have access to quality care? Do they really have access to care, period? Mm. And we need to try and level the playing field. Luckily, though, which is the only reason I got into talking about health insurance, is that these types of plans, like that you and I talk about on a regular basis, that Health Rosetta advisors talk about, can be equitable. They're designed that way by a standard to say, like what we do on our plans now 100% of the time is, here is a direct primary care provider. Every single person, no matter how much money they make, here you go. It's built into your plan. And that means there's zero copay to go see that doctor anytime you want. Call them, text them, whatever means works for you, the human being on the plan. And that to us is really, really important, which is why I'd like to try and reframe those conversations with the C-suite and our colleagues too, just to say, remember what you're doing here. You know, this isn't just about selling a better model of health insurance. It's not about that. It's you're providing better health care for all these human beings. And I think it can help people be energized to talk to the C-suite about something they probably kind of don't want to talk about anyway, which is, you know, deductibles and copays and health insurance and all this other stuff that doesn't fire people up.
Yeah. And, you know, it's funny because when I saw the cost for the first time 5 years ago, it really got me questioning everything, right? You just, you know, these are our trusted partners. These are, you know, trusted advisors. And no one's to blame, but everyone's to blame at the same time, right? Because we all fell into this trap that we stopped questioning because the lack of information over a period of time just gets you to think, well, you know, I have to believe that I'm with this carrier and they're doing the best job because they're so enormous. They must be getting the best they right. And they may have been a time when that was true. But more and more what you and I see behind the curtains, what we're trying to share with people is that they're not getting the best prices, right? They're getting the best profits. I was on a show yesterday with Eric Silverman, and I don't know, it just popped into my head. It's kind of like an English muffin, right? From the outside, you see all of what do you say, cornmeal. It's very consistent, it's delicious. When you slice it open and you look inside, all those nooks and crannies that are in there, those are all the opportunities to hide profits. Yeah. Right. So we're misinformed, but we're underinformed, and it's very deliberate. You mentioned direct primary care, and probably not everybody that's out there is familiar with that concept. I know a lot of the people that I invite are here in the Northeast. We have very limited access to direct primary care doctors here. There's literally one on Long Island, Dr. Blytheskull, and I'm going to have her on one day. I really have to get her on. And I sought her out as a broker. Now, direct primary care doctors, for those of you that don't know, these are doctors that are so fed up with the fee-for-service managed care model that they gave it up. They do not work with insurance companies. They don't submit claims. You pay a reasonable monthly fee, what we've seen anywhere probably from $65 to $100 per month on average, and that's your doctor. And every state allows them to do a variety of different things. It's everything a primary care doctor can do plus things,
Yep.
some things that specialists can do. And depending on the facility, they have internal, testing and some radiology work, things of that nature. But really the importance of it is they are now your guardian. You don't spend 5 minutes with them. You spend generally no less than 30 minutes, up to an hour. There's no waits. Their appointments run on time. They do not have to have people in their office. Ours doesn't even have a receptionist. There's no need for one.
No.
When we met her for the first time, and I walked into this office with my daughter, and I sought her out for my daughter because my daughter's been treated for a variety of different things for a very long time. Nothing helped. Spent 5 minutes with doctors. They increased her medications. None of them got to know her. Within 1 week, my daughter had about 15 different interactions with this doctor. She made her year's worth of compensation, in 1 week.
Yeah.
Over every prescription, so it's something I know is growing. I'm a Forbes Business Council member. I was just on a call a little bit earlier today, but 2 weeks ago I was on a call. And when I mentioned what I did, and I mentioned the term direct primary care, and I was referring to this whole entire ecosystem of healthcare that people don't even know about, all of these finance people from Forbes jumped all over this and said, what is that? Because they see so much money, private equity money, entering that space, which is reassuring because we know that there's change coming. A little less excited about private equity because eventually the profit motive possibly. But I think at its core, it's such a great thing.
Yeah.
Right? And it is different. It is different. We haven't found a way to embed it into all of our plans because it's so limited.
Yeah.
But we are talking to people every day about that because fundamentally, there's no care in healthcare. There's no benefit in employee benefits anymore. We use these terms as if they still exist, but and I'm not trying to bash anybody. I completely understand how employers got from $5 copay to a $7,050 deductible today.
Yeah.
$14,100 for an HSA compatible health plan.
Yeah.
Is that insurance?
No.
Right? You are you going to avoid care? Absolutely.
Yeah.
When we rebranded the company, our whole approach, our strategy, everything about what we're doing is different and focused on the members. Because when I had time to reflect, when I left the GA world, I reflected on all of those personal interactions I had at the end of open enrollment meetings when I said, I will stick around for any personal questions that you don't feel comfortable bringing up in front of the group. And those are the ones that really haunted me.
Yeah.
I really, I went from feeling like Captain America. I got my little Captain America glasses here. I felt like that. I felt like I'm doing such a great job. And those moments that I reflected on after now knowing, having the hindsight now of knowing, wow, all of this profiteering is happening. These people crying on your shoulder. And it doesn't seem like a lot to so many people, but all we did was change a copay on a prescription from $10 to $25. That $15 difference means a lot to a lot of people these days who are already deciding which prescriptions to take. There's people out there with 10, 15 prescriptions a month and more. They're very costly sometimes.
And these are all the causes why people are not getting healthcare, right? This is how it's not equitable because you think that whoever's making the decisions oftentimes generally don't believe that a $2,800 deductible is a big deal. But you ask the right people, you ask them about their savings, you go look at the data about how much money people actually have in their savings account in this country on average.
Yeah.
Those people are not being attended to. $2,800 is tragic. It is a very big deal for a lot of families in this country.
I looked it up. I looked it up just a short time ago.
Level it out.
Yeah.
Yeah.
I think the average, now keep in mind, it's the average, is about 5,000.
Yeah.
Or the median was 5,000. The average was much higher, but you're talking about billionaires and millionaires.
Yeah, right.
You got to take them out of the equation.
Yeah.
5,000 is the median. That means I saw somewhere as much as 70% have less than 1,000.
That's the stat I've seen, and this was in a something published about Ohio, which is the state I live in right now. So, but I think, there's a lot of rural areas in Ohio, and there's a lot of cities in Ohio. But I think for it to be anywhere in like $1,000, $200, $2,000, $3,000 of savings puts people in a real bind because that is all their their deductible is their savings.
Yeah,
they are going to avoid all the care they possibly can. And it also, we see in the research, it influenced their preventive care, which is also free, but either people don't understand or they're afraid it might not be. And what if I don't? So that in and of itself is where I started the conversation about your plan isn't equitable, and I'm not trying to call you out as the CFO, as the HR VP of HR.
Right.
I'm just telling you, we're going to design your plan differently. And if that sounds appealing, let's keep talking, because that's the only way we're going to do it. And DPC, direct primary care, is a brilliant starting point.
It is, absolutely.
You can go for as much, as you said, as much as you want.
And, you think about those numbers I just gave you, right? So if you're doing it on an employer basis, it's even less expensive generally, right? We did it individually for my daughter.
Mm-hmm.
It was something that we needed. Yeah. This particular doctor, couldn't absorb that many. And because there's such a limited supply here. But, so, all right, $50, let's just say $50 per employee per month to pay. Sounds like a lot of money when you add it up. But if you think about it, and I'm sure that what you've seen is that the end result is that you are avoiding so much other unnecessary care.
Yes.
Tests. These doctors have no misaligned incentives.
Right.
They are not beholden to the healthcare system, the hospitals. They're not told what to do. They have no quotas. I always think about, driving around at the end of the month. You got to slow down about 5 miles an hour, because those police officers out there, they have a quota to meet on their tickets.
That's right. They have incentives.
I don't want to be that guy.
That's right.
Doctors work the same way.
That's right.
We have a great doctor that we've seen. It's a specialist, and I'm writing a book. It may or may not ever be finished, because I'm a procrastinator. But my doctor, I'm just going to call him Dr. B, was going to be in my book. Unbelievable doctor. Went to him for the first time about 5 years ago. I needed my colonoscopy as a gastroenterologist. He spent 45 minutes with me talking about my health and my weight. I said, I'm only here. I'm here for a colonoscopy. He says, yeah, but that doesn't interest me. You interest me. I want to know more about you. And I was like, this is insane. People don't get this.
Drastically different.
I went back 3 years later, because there was some things precautions he was taking. So I went back. I'm good. But the healthcare system sign was on his building. And I walked in. I said, Dr. B, what did you do? You sold out. He said, Lou, he has 2 practices. He has a specialist office, and then he has his outpatient surgery where he does all the tests and everything. He said, my office, I partnered with the healthcare system. I have not gotten a penny more, almost not a penny more, in 15 years. Immediately signing that piece of paper that I'm with the healthcare system now, they're doing the negotiations for me. I got a 20% or more bump on all my services. He says, how couldn't I do it? And I said, okay, but they're not going to be happy with you, because you're still spending 45 minutes with me. It's just who he is.
Yeah.
I am sure you're not hitting the numbers. They're going to, at the end of the year, they're going to be very unhappy with you. I'm interested to see what happens when I go back another couple of years from now, if it worked out, because it's, it's just a different world of healthcare.
Completely
and when you look through it with a different lens, which is what, when you bring, can I call you Aaron? I'm a big Key and Peele fan.
Yes, you can.
Aaron, I can't do that.
You can call me Aaron. That's about. I've had a lot worse nicknames than that.
Yeah. So Key and Peele, I just love them. They're hysterical. But when you bring someone like you in, which most people probably don't even know exist, right? I mean, let's frankly, there's not enough, booze or advisors that are doing things differently.
Yep.
That are bringing. So the way I look at it is, we're bringing the solutions that need to be brought to people, not what they're asking for. A lot of times they're not ready.
They don't know.
What I am sure that probably 80% of the people that you approach and talk about direct primary care have never heard of it before.
That's right.
They have no idea. So sometimes it's a year, a 2 year, a 3 year conversation where now all of a sudden, for me, the important thing is I want to be memorable. I want to be the boo. I want them to, when they get their renewal, that 20% renewal that they settle on 8, and 20% they settle on 8, and 20% settle on 8. Then at that point, they're like, who was that person? And they'll remember Boo. They're not going to remember Lou Bernardi. But they'll remember Boo, and that's what's happening.
Yeah, that's good. It should.
Well, when you think about the economy now and the uncontrollable things, it cost, other parts of the country probably even worse, but it cost me $4.99 for a regular gas this morning.
Yeah,
I can manage that. A lot of people can't.
Yep.
They have to do it, right? You can't boycott. Some people's jobs require them here. We have a lot of mass transit, but still the highways and the byways and they're full in the morning. You can't avoid that.
Yeah. No.
I just renewed my gas, my oil, my furnace, my fuel oil, heating oil. I was paying $3.69 a gallon last year. My company wanted to renew me at $6.20.
Ooh.
Now we're going into the summer, so that's not a big deal. But this isn't going to be resolved come November, December. No. What are people doing to heat their homes?
That's right.
Now, how many people aren't going to be able to afford those tests? Healthcare, unfortunately, it's avoidable until it's not.
Mm-hmm.
We don't want that. Direct primary care, there's no barrier. What's the barrier? There's no cost to that person.
It's a transportation issue at worst. But anyone that's listening that sees this and isn't quite sure what it is, one of the absolute best parts of it is that they don't want you to come into the office very often. They want you to call them, text them, video chat them, so that you only spend the amount of time that's necessary. There's never any overutilization. There's no extra driving time. There's no coming in and going, oh, I could have done this over the phone,
right?
Because I already know who you are. It again levels the playing field. There's zero excuses. Again, transportation is not nothing, but otherwise zero excuses not to have a call with your doctor the same way you would if your brother or cousin is a doctor. Because when you think your kid's sick, that's who you call. Cousin Bob, hey, little Josie has her, ear infection, I think again. Oh yeah, ask her this, and this. All right, just send her to CVS. We'll go get it, go to the drugstore and we'll get it figured out. Yeah. That's how it should be. And that's what it's like for these direct primary care plans and these direct primary care offices all over the country, all over the place. Some more densely than others. You're in one of those tough areas.
Yeah.
We've seen other areas like that too. And it does cause some hurdles. But
I am so dug in. Sometimes it hurts, but I am going to see this through so that we're going to build centers. Not me personally, although I am handy. I could lend a hand in that.
Yeah.
I'm going to talk to as many employers and build shared DPC facilities. I think we need something like 1,000 members to get that going with, depending on the companies. People understand, a smart, savvy business owner understands that not only is this investment going to save them money over the time, over a period of time, it's going to create a healthier workforce, a more committed workforce, lower turnover, all these things. My oldest son, he's going to be 30 this year. He just had really severe heartburn, acid reflux, right? Went to the doctor, had to take off work. Went to the doctor. 6 weeks later, doctor wanted to see him again. Spent 5 minutes with the doctor. I had to take off work again. Saw the doctor for 6 minutes, says, how's it going? All right, I want to see you in 3 weeks. Right? Lost another day of work. The employer lost a body.
Yep.
He's a contractor, so he's a steam fitter. He's it's not just sitting at a desk. It's real work. A day's lost labor out of someone like my son is significant money. Wants to see him again. Wants to do another test in 6 months. My son said, well, since I've been on the prescription, I haven't had a problem. If I take it, I'm good.
Yeah.
But fee for service model, and people don't understand maybe that, when you think about that term, fee for service, your doctor, most likely, primary care doctor, specialist, whoever, only gets paid when you see them. Yep. And they will create reasons for you to see them because they want to get paid. Absolutely. As opposed to a direct primary care doctor that says, I'm going to see 1,000 patients, not 5,000.
Yeah.
I'm going to collect $65 from 1,000 people. That's $65,000 a month with much lower overhead. That's not bad. There's expenses for running offices, liability, and now this doctor, she was so chill. I got to tell you, we spent an hour and I was just in amazement. I said, I remember that I'll be 55 this year in September, from Brooklyn, New York. My doctor, Dr. Zimmerman, lived 2 houses away from us. His office was in his first floor of his house. And you saw him every single day walking around with his leather briefcase doing house calls.
Around the neighborhood, yep.
He knew everybody by name. Yep. He cared, right? These were his people.
Yep. Getting back. We're getting back to that.
And doctors want that. They want that kind of relationship. They want to help people. They want to keep people well, not treat them and earn money.
Yeah.
Not to keep them sick. No, I don't I hope doctors aren't looking to keep you sick.
No.
But they're looking to run an office, and that's it's a very, very expensive proposition. I think Dave Chase from Health Rosetta always throws out the number. I think only 26 cents out of every dollar spent on health insurance or healthcare actually goes into the practitioner's pocket.
Yeah.
There's so much waste, right? I mean, it's just insane. You think my chiropractor gave up. My chiropractor said, I have to do so much paperwork to justify people coming here. He says, we won't do it anymore. Yeah. Just give me your copay.
That's right.
Give me $30. I'll crack your neck. He hates when I say that. It's a lot more than cracking my neck. But it's crazy. So are there any other things like you could think? And we spent a lot of time talking about direct primary care, but when you're talking about equity versus equality, things like that, one things I think that so I call them members when they enroll on a plan, but it's really patients and people, because it's when they actually go to use it, that they get very surprised. I actually had one of our clients call me about an hour and a half ago. It's the HR director for a company. She got an ER bill, and she was so surprised by the bill, the balance bill. After the insurance paid, she owed several $1,000s for an ER visit. And when she conducted open enrollment, which she helped us set up, and we did it electronically through a portal, she selected the mid plan, probably based on the per paycheck contribution that she was asked to make, and didn't look at the fine print. And it was right there. It wasn't like it was hiding behind an 8-page summary benefits and coverage. Emergency room subject to deductible and coinsurance. $3,000 deductible, 50% coinsurance, right? And she went there, probably something that could have been handled at urgent care, most likely could have been handled by a direct primary care doctor.
Yep.
Right? It didn't seem like an emergency, but maybe at the time that's the only option. The fact is, people don't have a primary care doctor right now.
They don't have anyone they can call and ask. Like, I don't know if it's an emergency or not. Who am I supposed to call? I just go.
You got to wait 3 weeks to see your direct primary care doctor if you haven't given up on that person yet. People have been using urgent care as their direct primary care doctors, and I get it. They're open, some are probably open 24 hours a day, but they're convenient. They're there, a little bit of a wait, but they're money makers, right? They're owned by the healthcare systems.
Absolutely. And it's not a relationship like you were talking about before. I mean, I think that's one of the major downsides to people relying on these retail offices or an urgent care to get a lot of that care. You can get it, and it is more efficient, but you're not building a relationship. You're not creating a medical chart that someone can tie back in and really learn who you are, like Dr. Zimmerman on your block. Right? That is important. It does make a difference. And we work with, I think, 45 DPC offices around the country, literally from Tampa to Anchorage, Alaska right now.
Right.
I mean, they're all over the place. Some of them are more spread out than others. But my point in bringing that up is they want to go back to what Dr. Zimmerman was doing, and they won't take some of our patients on until they've onboarded them. They've had deep discussions. They've said, you're in my practice. I know who you are. Let's proceed. I can't just say like, oh, here are your 8 patients from this new client. Right. Most of them will go, hold on. Let's make sure we're a good match for each other. And that was very refreshing to have to do, to be forced to do. That's for the patient's benefit, for the doctor, but for the patient's benefit overwhelmingly.
For the patient. Imagine if that was like the clause, right, that everybody followed. For the patient. I can't reiterate enough. There are so many different solutions. One of the things, and we did have a question about, will this recording be available? Yes, this will be available on LinkedIn immediately after the show. The tape goes live. It'll also be on Vimeo. It'll be on Spotify and Anchor, and we're looking to get it on Google and Apple. I just found out. I'm not a big podcast guy, but we created one, so we might as well.
You might as well get up at the times. Yeah, what all the kids are doing.
But we've identified, and I usually share a slide at the beginning of the show, but I just want to get you on right away today. There's a couple of big problems that people aren't aware of, or at least subconsciously they are, but they're not thinking about it when they're making the when they're making their purchase, right? And employees can't pick their own insurance carrier or plans. It's whatever the employer makes available. But the biggest problem is patients, when they need care the most, do not know who to go to for the best quality, and from a financial standpoint, what's it going to cost me?
Mm-hmm.
Is there an option? Is the cost different at different locations? And I can tell you undoubtedly, and I know you know this, absolutely. I was talking to someone yesterday, and they said, she shared with me, it was a prospect that we were talking to, and she said, as I was talking, she said, that just happened to me. And I had just mentioned the fact that, all right, you need an MRI. Your doctor probably works for the healthcare system. He doesn't know what the cost is, but he's told, it used to be like, he'd be like, oh, go to the front desk and they'll give you some names. They have pieces of paper now. It's like, oh, here's 10 places, all the nearest locations to my office within our healthcare system that you can get that MRI. I can guarantee you it's 5 times the cost of the independent radiologist waiting at the corner to help you. But they make it so easy. You can walk down the hall. You can walk down the hall today and get the test. They have an availability because they always do.
Yeah.
And she said, it cost me $3,000. And I use that as an example. She said, that's about exactly what it ended up costing me. I said, and the shame is, without insurance at all, you probably could have paid $500 cash that day.
Yeah.
We know that. That's a different conversation completely. But by direct contracting,
yes,
huge thing. Again, some of these things are only available for larger companies, depending on your state. That means different things. Direct primary care is available to anybody. You can buy it as an individual. You don't only have to buy it through it's not something that you can only get if your employer sponsors it, is very important too.
Yep.
When I learned about it, I said, there's so many people, we can't sell individual plans in New York, but I know for a fact that a majority of the plans that are bought from the state marketplaces are silver and bronze plans with high out-of-pocket cost, really big deductibles. A lot aren't subsidized because of the family income level of the people. And they don't know. So now they got this $14,000 family deductible. It's only there for an emergency. If they knew that they could sign up for a direct primary care doctor, potentially for the entire family for, I don't know, I think I've seen $200. I don't know if that's a fair number for family, maybe 3 members of a family to enroll.
Yeah.
About right?
Yeah, I think it depends on where the geography makes a difference.
Yeah, absolutely. Right. You can probably get it a little bit less. But even if there's just one member of your family that really needs health care and you say, listen, I can't afford all of that, but for $75, I can make sure that, my child or my wife or myself has access to a direct primary care doctor where there's no other out-of-pocket cost whatsoever. I think most people would.
That's a big deal. We go.
Yeah.
I mean, right? We're talking about this equity, and like to even touch on functionally uninsured. That's what that means. When you see that you cannot afford the deductible to even get started with the care you think you need, you are uninsured.
Yeah.
But you have a health plan through your employer, so you are functionally uninsured.
Right.
And when we use that term, we start to talk to employers about that. Say there are a lot of ways to level the playing field, and you'll be shocked at how affordable this is for you as the employer. And exclusively on these, I mean, I'm telling you, 100% of the time, the cost goes down.
Yeah.
I'm talking about add in direct primary care at $75 per person.
Right.
Yep. Reduce their deductible down to, frankly, zero. We have a plan on every single employer where the deductible is zero, and the other one is $1,500. That's it. Those are the 2 plans. And we get employers that push back on that. Well, couldn't I, if I raise the deductible, couldn't my cost go down or my premium? Sure. Well, we don't think that's a good idea. And here's why. Right. Because again, the idea is don't create any barriers, any hurdles to primary care, because that is what 85% of your humans are going to go through in any year.
Right.
It's only that other 15, maybe 20% of the time they're going to actually need specialty care or specialty medications. So don't create barriers for primary care of any kind, including chiropractic, like you mentioned before, physical therapy, mental health. We've got to lower the barriers for that. And that levels the playing field. And then we just ensure, as you alluded to before, that they go to high quality specialists.
Right.
High quality. Luckily, the cost will almost always be lower when you do that. And we'll screen that out and make sure that's the case. But when you have a $0 deductible plan with a free primary care, now people go, regardless if they make $14 an hour or $80 an hour, they go. And we see primary care utilization go way up and we see specialty care go way down.
Yeah.
You mentioned that earlier, like that's the trend you see. And that reduces the overall cost for the employer, which is ultimately what they're looking for. Now, our best clients are the ones that say, I need my cost to go down and I love my people. It can't be only the first part of that. They just don't, they're not bought in yet. They're not ready. And that's okay. But it's a fantastic benefit when you get that far.
Well, you know, when you're talking to the decision maker, right? You're talking to a business. They can't ignore the fact that this costs us a lot of money right now.
Yeah.
Right. So the cost might be on the forefront of their mind, right? That might be the deciding factor. I know you and you know me, and that's not the goal. The goal is to get people the best care possible. It just so happens that the way we're doing it and with the partners that we're bringing in, there's getting back to that English muffin. There are so many hidden profits. We're taking them out. We can't always take 100% out, but we're going to make them transparent. We're going to partner, and we're never going to stop looking for even better partnerships. We're going to keep our partners accountable because the goal is to keep people healthy. When you keep people healthy, the cost goes down.
Yeah.
But when you extract all of those spread pricing on medications, rebates, make sure that those are, coming back through to the employer, that you're addressing the outlier claimants, those high cost claimants, and you're giving them nurse navigators, concierge health, where people are going to proactively reach out to them, says, hey, we're here to support you. You don't get that from your insurance companies, right?
No.
Guide people through the process, make it easy for them, right? And I've told some of our clients, I said, okay, we need to let the employees know that this is a little different, and it's not different in a bad way.
A little bit.
But it's going to be, there's a very good possibility that someone may reach out to one of your members who's been identified as a, potential high risk for something, or maybe they're not adhering to their medication. We're really, there's not that much more. I would argue a lot of times there's no more work for our employer partners.
Yeah.
But there's a lot more education involved.
Yeah.
And when they start seeing it, they don't want to go back to doing business.
No.
For the people that are out there, what we're talking about, you might say, well, we're a small company. All of this might not relate to you. If you're a large enough employer, which in New York and probably most states, 100 plus employer is almost always going to be at least partially experience rated. If you're self-insured, that obviously your claim spend is really crucial. But at the heart of everything is the expected claim costs of a company. And insurance carriers will add a 20 or 25% corridor above that, the expected claims. If you reduce the claims because you're supplementing your benefit strategy with other solutions that extract all of that waste and the unnecessary care. And that's one of the real fundamental things of direct primary care, I think, is that I think 80% of all exams and tests and surgeries are unnecessary.
Yeah.
At the end of the day.
Yeah.
A good doctor helps their patients avoid that unnecessary care.
Absolutely.
Right.
Like they don't need, you ask them like, well, members will ask, well, where am I going to go for my MRI? Will you tell me where to go for my MRIs? Will you tell me where I have to go get my lab work done? Will you tell me where I need to get x-rays? Yes. You'll have a lot less of that. Trust me. Those are not going to be as necessary as you thought they might be. Oh, I sprained my ankle. I should probably go get an MRI. Probably not. And that may have felt like the natural, normal care pathway previously in your fee-for-service environment. It's not going to feel that way. Your doctors are going to use as many modalities as they have at their disposal, and then they're going to refer out to physical therapy or chiropractic or occupational therapy or any other therapy that you have at most of the time zero cost or very affordable cost. Because again, we've got to get rid of the hurdles for primary care.
Right.
And it's not expensive for an employer to do that when they start to realize that doesn't, wait, you mean I can pay 100% for primary care, an OT and PT and all these things, and my cost isn't going to skyrocket? No, because those are not expensive.
Right.
They aren't expensive. What's expensive is getting cancer treatment when you don't have cancer, or getting a knee replacement when you don't need it, or a back surgery before it's time to have the actual back surgery. That crushes your plan.
Right.
We just want to really make sure that those kinds of things don't happen, because frankly, no one wants to go through any of those.
No.
So let's just screen it out. And then when you do absolutely need that back surgery, we'll just make sure you go to the best, best person in town, the best person in your region. And then you don't have to worry about it. If you go where we ask you to go, you'll pay almost nothing.
Right.
Because it's better for everybody.
And that ask, just to be clear, that ask isn't about cost whatsoever. It just so happens that the best doctors typically do cost less. They do it more. They're experts at it, right? I know you know Nurse Deb, and I haven't had the pleasure of working with AIM yet, but I loved one of the presentations, and I think it was at the U-Powered Benefits Symposium, right?
It was a powerful one.
Oh my
God,
God,
after them.
So U-Powered Benefits was a symposium that E-Powered Benefits, Aaron and his team over there, held in Phoenix a few months ago.
Uh-huh.
And Nurse Deb, who's pretty famous within our world for sure, was up there, and I almost had to walk out. I'm a pretty emotional guy, and when she played her video, and there was one segment in particular where it was a couple, and they were probably somewhere in the Midwest, young couple, probably in their early 30s, and they were talking about a surprise medical bill that they got because they had to take one of their children to the emergency room, and I saw the absolute. I don't even know what to tell you. I get kind of. I get kind of choked up when I think about the helplessness in the father's eyes.
Yes.
Saying, this was a company that needed this like a hole in the wall.
Yeah.
And they were steered through the healthcare system with complete disregard to their plans. Now, if you go back 10 years ago, and I talk about this all the time, this process that managed care went out. Yeah. So, here in New York, and a lot of people don't know this, early days of managed care, almost all of the plans were filed as HMO, under HMO contracts with the state, which is different than an indemnity contract that a PPO or EPO plan. It's a contract, but HMO plans had stricter guidelines on them. And there was a point where in New York, the copay for a specialist was not permitted to be more than $50. That's where the original New York State law was enacted. And we went from 5 to 10 to 15 to 20. Then we went to the split copay. I don't know if you remember this. $20 copay was across the board, primary care doctor and specialist. And then all of a sudden they're like, wow, we need to do something. So they did a split copay and they tricked everyone. 20, 40. And we had to explain that till we were nauseous. Well, the 40s for specialist and the 20s for primary care doctor. What's a primary care doctor? The whole story. Mm-hmm. And then they got to 50 and they had a problem.
Yeah.
All of the insurance companies, again, it was happening. I wasn't really conscious at the time exactly why this was happening because they weren't inviting me into the boardrooms. They had a problem. They had no way of increasing premiums.
Yeah.
Because without it really hurting people and maybe them losing business. So they had to refile all their plans under indemnity contracts. And then they got the go ahead 50, 75, 100. And then lo and behold, deductibles came back in.
Mm-hmm.
All of a sudden, what's a deductible? Don't you remember 10 years ago you had it? So now look where we are. We're at $7,000 deductibles.
Yeah.
It's I tell people it's not broken, and I know you guys talk about this a lot. It's not broken. It's working exactly the way it's designed to work.
Mm-hmm.
And I think the healthcare system and the health insurance ecosystem, this is a turning point. They are watching very closely to see what the American healthcare consumer is going to do.
That's right.
Right. And in my book, I talk about the reawakening of the American healthcare consumer. We are consumers. We drive markets. Businesses have to change sometimes on a dime because our purchasing goes elsewhere. Something comes up, that people thought, look, Blockbuster people, they're still going to come in. They love coming in and
Right.
they love the 3-day rental. They didn't pivot quickly enough. Healthcare and health insurance right now are looking to see what's happening to our bottom line. Transparency laws are going to mean that certain profit centers are going to dry up.
Yeah.
But they're creating new ones.
Oh yeah.
They're creating new ones, right? They, all of these mergers and acquisitions, they own every component. They own the banks that do the HSAs. They own the PBMs. They own the case management companies. They own the insurance companies. They own the doctors. The healthcare system is trying to get into insurance. The insurance is trying to get into healthcare. And the consumer.
The consumers can drive all of this activity, and employers, that's why they have such an impact. They can have such an impact on this because then they influence all of their employees and their family members.
Mm-hmm.
But consumers will change this. We have to be the push, the nudge to say you can do this better.
Yeah.
But if we think that the big players, whether they're healthcare or health insurance related, are not on this already, they're not already talking about buying direct primary care offices and building new direct primary care offices to be funnels into their hospital system or be value-added resources as part of a health insurance plan, we would be naive. It's absolutely on their radar. They could do it today if they really wanted to.
Yeah.
They don't, and they don't want to have to, but there will be a continued battle over independent providers and those that work within a hospital system.
Right.
And especially well-resourced hospital systems can do it tomorrow if they really wanted to. And there's some in your neighborhood and there's some in my neighborhood in Cleveland, Ohio, like that. But they'll only happen when consumers demand it.
It's about thinking in every other aspect of our life. We demand information because we expect it. We don't even expect it in healthcare or health insurance. So we just go along. Yeah. We've been groomed. Slowly but surely, the consumer, brokers were groomed. Brokers, I talk about this all the time. I do not blame anybody for this. Yeah. However, it's really hard to avoid the fact that the deliberate withholding of actionable data, prices, that blame has to be pointed at insurance companies and the healthcare system.
Yeah.
Right. You call you call up a doctor today and ask them, what's this going to cost me? They still can't answer it, even though there's laws that say they must.
Yeah.
People don't know about the compensation disclosures. They don't know about the transparency in pricing.
No.
They don't know about all of these things and things that we talk about every day. We got all of our compensation disclosures out all the way through May of this year's accounts. We sent them out. We sent a nice email and we said, we've been waiting for this day.
That's great.
We've been waiting for this day.
Yeah, that's great.
We have nothing to hide.
Yeah.
And the consumer has to ask some hard questions.
Yeah.
Can we do better? Ask your insurance brokers, your partners, where's our data?
Yeah.
I learned something earlier this week that I didn't know about because of the release of the gag orders. Your insurance carrier can't withhold, even on a fully insured plan. You're entitled to your data.
Which doesn't even sound like that's a stretch. That shouldn't even be a stretch. Like, yeah, so of course I should.
And people out there be like, what data are you talking about?
Yeah.
Right? When I saw the data for when we did our first, and you guys are a little ahead of us, I think, but when we did our first pharmacy analysis, prescription price, cost analysis, I nearly fell off my chair when I saw $2 medications that, I won't name the carrier because I don't like to do that their insurance carrier was charging $80 for. Now, the member was only paying $5 copay.
Sure.
Bad enough, charging, $5 or maybe they were only laying out $2. I'm not there at the point of sale. Hopefully they're paying $2 out of their pocket. But the health plan was being charged $80 for a $2 medication because of the spread on that. And what we identified is about a 53% unnecessary cost in their pharmacy. This is a company that to date, because we did move them, thank goodness, they trusted us and we went independent, TPA, PBM, their pharmacy costs are down 50%. And that's going right back into their employees' pockets. They called us up 3 months into it. They said, we want to enhance our benefit package.
That's great.
Because they saw their monthly costs going down.
Yeah.
And like, we're having such a hard time hiring people. We want to enhance our benefit package. We want to be the place to work.
That's the stuff. Right. But like, sure. And we do talk to employers with like the benefits, or friends of mine we'll talk shop a little bit about what I do. Like, oh, I have really good benefits at oh, that's good. I'm glad you have $5 copays. Guess who's eating it then?
Yeah.
Your employer is eating it. Now I need to be talking to them, because guess how much better your benefits are about to be if their eyes are opened and they can come to Aaron and go, you're telling me I'm paying 30% more than what I should. I was about to say market, but that would be silly because the market is incredible. But like, you can trim my cost by 30%. Yes, probably within a year, maybe 2, but yes, absolutely. Right. And then they go, so you mean like I could have $0 deductibles? Like, could I make those medications free? Yes. Yeah. Your employees will love it. You won't ever lose them, because they'll have to think real hard if they're going to leave you and go to somewhere else who hasn't done this yet. And especially now with this shortage, and just, it's incredibly hard to find support. These conversations are coming up like that. Right. And so I, sort of selfishly tell friends of mine and acquaintances, like, you might have good insurance, but if it's that good, you probably should introduce me to your HR, CFO, president, so that we can have that conversation. I can make sure that they're not, taking it on the chin as the employer, as a nonprofit or something. A friend of mine's in a nonprofit. She's got excellent benefits. I looked at their stuff. They are getting killed, and it's a nonprofit.
Yeah. Yeah. Nonprofits are definitely an unbelievable opportunity, because typically they don't pay significant wages. They have to offer rich benefits in order to attract people. I had a cemetery client very similar to that. At one point, he says, could you imagine coming here to work every day? He says, we have 100% coverage. We pay 100% of the premium, but their cost was twice what it probably should have been. And it was before we even had access to data, but I knew, I was like, I get it. Yeah. I get it. You have to do what you have to do to keep employees. Getting back to the whole, functionally uninsured aspect of it, they're also functionally uninformed, right? So what are you guys doing to make sure that your employees, because you said, well, you're going to tell them where to go, but there's still an option, right? So it's not like you're mandating go here or no benefit. Mm-hmm. You're saying you can go here, and it's going to cost you your out-of-pocket costs under your traditional health insurance plan. Mm-hmm. But we are so passionate about sending you to the highest quality provider. If you go to this tier 1 provider, it costs you nothing. It's not with the profit motive, right? It's not, well, we're going to send you here because it costs less. We're going to send you here because it's the best thing for you. Yeah. And your employer truly cares about you and knows you are starving for that kind of guidance.
Yeah. By the way, think about DPC at $75 per member. That's not cheaper than primary care. It's just better. And it will make it cheaper ultimately for you and the employer, but it's not cheaper. So that's not the option to go if you're trying to look to cut corners.
Right. No, absolutely. I agree 100%. There's not enough time in an hour conversation to really talk about everything. One of the things that I'm really passionate about, because, we have 2 different types of prospects here in New York. It's very clear and defined. Under 100, you're still fully insured. The only way outside of the normal insurance carrier model is really PEO. Yeah. Right. And then 100 plus, you have a lot of different options there. But for the small groups, what we recognize is way too many of them went the way of the HRA. Yeah. I say, we have a better way to HRA, because you're buying a plan, you're saving this bundle of money. Everybody knows what the strategy is, right? We started with plan A, we went to plan B, we have this bucket of savings, and we're going to cover the out-of-pocket costs. And our bet is that, we're probably going to pay less than 50% of that back to the employees. And I get it, but it could be so much less, because what you haven't solved for is the fact that you're still a victim of that steerage of the healthcare system to suck every penny out of you and your employees. Yeah. Even though you're funding it and your employee's whole, your employee got no guidance. There's no guarantee that they're seeing the best doctors. So, we're really excited about some of the things that we're going to be doing to help those people get that guidance that they need so that the employer can retain more of the HRA and use that additional savings to enhance benefits.
Yeah.
Maybe to increase pay that they've been withholding. And everybody knows that Kaiser chart, right? Where I think out-of-pocket costs have increased by 162% in the last 10 years. Premiums have increased almost 100%, I think. Wages have not increased, right? I think they're starting to now out of a matter of necessity, potentially.
Yeah,
but inflation is also
by the employers.
But inflation is now at 8.3%, I think, as of yesterday. So when you think about that, even those higher wages now all of a sudden are gobbled up by the cost of living. And let's hope it's temporary. I don't like to get into politics, but we can solve for so much of that.
Yeah,
we can help employers and their employees. What I really don't like, and I'm sure you agree with me, is that when I find after the fact that an employee made a decision based on what was coming out of their pay and didn't even look at the health plan, especially because most of our employers offer multiple plan choices. And we always see a majority going to the low plan. And I get it. And, 70% of people, that's probably adequate because they might not even go to the doctor once a year.
Sure.
But when someone who has, a health condition and has a, in a typical year, goes to urgent care several times, might go to the emergency room, takes numerous medications, and now they feel like, wow, I made the wrong choice and I didn't get any guidance. That's one of the things that we really are really trying to help employers. We want to do a better job, and we know that we need to do a better job educating the employer and their members so that they can make better healthcare decisions. So
we've got to. We because of this, you were talking about getting emotional about that story you told. Those are real human beings. This is not some sort of special story. She could have plucked hundreds of her clients, hundreds of our clients, your clients, and interviewed them about their medical bills, about their hassles with the health system. And we'd be just as emotional. It's not hard to find these stories. We have got to do better for the human beings who don't know how to navigate the system. They don't know what we know about the systems, about health insurance, about asking for a discount, about asking what the bill is going to be up front. They don't understand. And I think you were touching on like health literacy part of this, because you can't just drop a plan like this with a $0 deductible plan, direct primary care, intensive medical management, specialty surgical centers, and expect people to navigate it easily. And so we've tried really hard to do a lot of ongoing education with employees. Depends on where they are. Depends on how they like to get their communication. We've tried a lot of different ways. And one of the ways we're starting to understand we need to do is with a mobile app. People need to be able to just use that like they use many other apps. And luckily, smartphones, and it doesn't really matter what kind of smartphone, are pretty ubiquitous. People have them now and they know how to use them. They're quite easy. We've got to keep evolving to that level, like other businesses are evolving. Otherwise, people aren't going to be able to navigate it. They'll fall back to what's just easier. Let's just go with name X carrier nationally that my broker seems to bring up all the time. They'll just fall back to old habits. So we've got to take the responsibility to push it forward and say, no, ours is not only easier, it's better, and it's cheaper. So what excuse do you have as the CFO to CEO president to say no? Hopefully
the only barrier, and it gets back to maybe a point I made earlier, is time. They have to give you the time. If they truly care, and I tell people the conversation is complex, the solutions are simple. I'm almost always in my neck of the woods. I'm almost always the first person to have the conversation and says, hey, of course I want to see your renewal. I don't want to talk about your renewal just yet. My focus isn't on your premium. My focus is on your people, and it's the healthcare. Because you're buying healthcare. Let's understand what's happening here, and then I can help you spend a lot less on your health insurance. But they need the buy-in, and you know right away if they are committed as much as they are. If they're too busy and they want to go back to doing it their way, and they still only want to commit a 90-day window to it, they're not going to get the help that they need. And everybody needs it. There's not one person who's who's fully insured in this country that isn't paying too much for healthcare. There isn't. Show me it if there is. I challenge
100%.
anybody to show me that if there is. But
Mhm.
but this has been great. Thank you so much. It's in an hour, and we didn't even show one slide. It was amazing.
We don't need that. They'd rather look at your face than look at a slide anyway.
Yeah, well, I have some contact information here. So, of course, I'm Lou Bernardi. I'm here in New York, Woodbury, New York. I'll talk to anybody. One of the things, before I let you go, real quick.
Yeah.
I always get asked this question. This isn't a sales thing, but I'm sure that you share this thing. I always get asked by a lot of people, like, will you work with a 10-person group, or are you only working with a 200-person group or 500-person group or whatever? And I say, the 2-person group, the 500 and the 2-person group all have one thing in common.
Yeah.
It's people.
Yeah.
Those people are just as important to the rest of the people. So if they want help, I will spend as much time as they need in order to educate them and get them caught up. And
absolutely.
That's what I'm passionate about.
We have a 2-person group right now that is level funded, which can't happen in New York, but it can happen here.
No, got to be 101 or more.
2-person, 5, 6, 12. I just quoted a 15. And then we got a 200-person group in Anchorage, and we've got a 2,000 group in Pennsylvania and a 22 life group in Tampa. It's all over the board. And we're trying really, really hard to be able to not have to say no to anybody for that exact point. And you and I just selfishly, we want to say yes. And we want to be able to do all these things too. So luckily it's getting better. It's getting easier. We'll help whoever we can.
Yeah, Dale Sagan chimed in. Aaron prefers the 5-person group. He's a saint.
That's right.
He's one of our avid, he's an avid follower. I think he's been on just about since I met him. I think I met him at the U-Powered benefits.
Good.
Dale, yeah, and good people. And that's the thing. It's a community. There is a community of people there. If you're in Chicago, Illinois, and I can't help you, I'll find someone that can. If you're in California and just want to talk because it sounds different,
that's right,
I will help you find someone. This isn't about the Lou Bernardi show. This is about spreading the word, raising awareness, and helping people understand that there are better solutions out there. And we have to move the needle, and we have to push the market, and we have to tell the status quo that we can't take it anymore. We've hit the ceiling. There's not much further that we can go. You can't water your plan down any more than you have if you've already reached that $7,000 deductible. I know no one out there wants to do that.
No.
There is a better way. And if your current trusted advisors can't help you with that, I'll do a plug for Health Rosetta. Go to the healthrosetta.org website. There's a link there that has all the advisors in the network. If you can't find that, call me, email me. There's my contact information there. I will be more than happy to connect you to someone that can help you. And it will be just as passionate as you and I are about doing that. So anyway, thank you so much. I will see you soon, hopefully. You're going to be
in Austin, right?
All right, I'll be there. I will be there. I'll see you. Thank you so much. I'll talk to you soon.
See you, Lou.
Take care. Bye-bye.